Welcome, everybody, to the newest episode of The Animal Heartbeat, the only podcast dedicated to the topic of veterinary cardiology. I'm here with Novo Matos, and I'm Kieran Borgea. We are joined for this episode by the fantastic, the brilliant Dr. Claudio Bussadori from the Clinica Veterinaria Gran Sasso in Milan. Claudio is not only a European recognized specialist in veterinary cardiology, but is also a human cardiologist and interventionalist. So he brings a unique perspective to the animal heartbeat. Thanks, Claudio, for joining us. And our topic to talk about today is around the subject of aortic stenosis.
Okay. Thank you, Kieran. Thank you, Josie. I'm quite happy to talk about this topic because I dedicated so much time about this topic on the breed screening. I would be glad to answer any question if you want to start.
I find it quite a challenging disease, actually, because I think, in school we learn about pressure gradient, but there's so much more, isn't there, than pressure gradient?
Absolutely. I think especially on the follow-up, one of the key points is to understand how to recognize the early stage, for example, of the systolic dysfunction. And so to make sure, I think the most challenging point is first, make the correct diagnosis in what we have been calling for many years, the gray zone. On the clinic, it's not a problem to make a diagnosis of aortic or subaortic stenosis. So in my 20 years of experience in pediatric cardiology, that was much easier because we were saying, okay, is a stenosis, not a stenosis. So they just the minimal, very mild stenosis. So we were discussing with the cardiovascular surgeon. They would say, okay, don't care about that. Follow up and so on. But then we have to do the breed screening. And the breed screening, for many years, we have been in some way blind. Some about the old story about the blind monks and the elephant and the Indian king. Well, everybody was touching some particular part of the animal, but they were blind, and they were not able to describe what kind of animal was. So for many years, we were evaluating only the gradient. And the gradient for us was, this is the breed screening, for us was the line between the good and the bad, the line between the white and black. That's not true, absolutely, because we were like the blind monks, we were only watching the gradient. Then, for example, we discovered that the gradient is not dependently only on subaortic stenosis. Only what we talk about, the obstruction, nodules, ring, or what else in the classic classification by Detweiler and Patterson, which is about 50 years old or 70 years old already, this classification. But simply, for example, in boxer, we breeded for many years everywhere in the world. Boxer really are different. In the south of Europe, the bloodline, the family of boxer is quite different than the boxer you have. I think it's a different breed.
Right. And very different again to the USA. Very different.
Exactly, absolutely. In our boxer, the main problem was that there was simply a mild hypoplasia of the aortic annulus and the hypoplasia of the pulmonary annulus sometimes. So they had really a mismatch between the body size, so for this the volume of blood, and the dimension of the annulus. About this, we developed a very good, thanks to the help of the breeder in Italy, in more than 30 years, we developed a breed screening that was focused not only in identifying the lesion, but identify and promote the breeding of boxer with an annulus larger, for example, of 70 millimeters. So suggesting this, they were breeding, now they are breeding, the average, we have data now for more than 6,000 boxers in, we started in 94. We have data, and that demonstrated in this year, the average of the size of the annulus is increased more than 1.2 millimeter, 1.1, 1.2 millimeter, the average size. It doesn't seem so much, but it changed. It changed even the peak velocity, because we were used to see boxer having 2 meters per second, 2.2, 2.1, and so we were calling that the gray zone. Maybe there is a lesion, we don't see the lesion. And I started to study this with transophageal, but this was not the way. The transophageal, okay, it's good, it make a better view, but the point was simply the dimension of the annulus.
If we just go one step back regarding, so we diagnose aortic stenosis on echo, and you talked about the cutoff, 2 meters, 2.2 meters per second, and so on. Could you comment on what your cutoff is? So if we start with breeding screening, could you just tell us which, like 3, 4, 5 breeds do you think are important to screen for this disease? And then what are your cutoffs? Where do you draw the line? Where would you say, okay, these dogs have aortic stenosis?
In boxers, I would say that the cutoff, I give a cutoff, but the cutoff is quite large, between 2.2, 2.4, 2.3 meters per second. Sometimes we have dogs who have 2.3, 2.4 meters per second. We suggest to retest this dog in 1 year, because even in boxer, not like in golden retriever, they get worse very rapidly. And they develop, especially after 1 year, they develop a worsening of the gradient. It's because of the aortic septal angle. In boxer, it happened because of the shear stress on the annulus, I would say, due to the small annulus, and they may develop higher gradient. In that case, if they increase the gradient from this 0.2, which is our limit, we say that this dog is positive. It's positive for subaortic stenosis. I don't know if it's correct to call that subaortic stenosis, but generally they have an aortic annulus which is less than 70 millimeter. And this 70 millimeter now is a sort of cutoff, not yet mandatory, because for treating and dealing with breeders, you don't have to be immediately mandatory. You have to ask them to get some responsibility about this.
Yeah, and I think that some of the issues that we identify with breed screening, certainly in the UK, is that if we're very firm on absolute cutoff values on echo, we might cut down the gene pool hugely. We might take a lot of dogs out of the gene pool and therefore create other problems because of narrowing down.
I don't think so. It is a multifactorial, even the genetical transmission. I will not eliminate this gene pool. What we did from the beginning in this breed screening, we identified several families carrying this sort of combined hypoplasia of the aortic annulus and pulmonary annulus. We had several boxers having this form. We excluded from the reproduction. Now we see that only in boxers imported from abroad.
How interesting.
And then, you know, that's what is so much hypoplastic that was similar to the Williams syndrome in children. In children, you have the Williams syndrome, they have hypoplasia of all the arteries, they have a genetic defect, they have some other malformation, even the expression of the face and what else, but they have some hypoplasia of the aortic annulus, pulmonary annulus. We eliminated that. And now the trend, since is multifactorial, probably multi-gene, but I don't know anything about genetic. I try to understand, but I'm done with these things. It's too difficult for me. Anyway, now we are increasing the size. Is increasing the size of this.
Claudio, can I just ask you something? So because that's really interesting. So what you are saying is we may have different phenotypes depending on the breed. So that's really interesting. So you are, let's say, just to summarize what you said. So you would, in golden retrievers, you see more, so these guys have more of a steep aortoseptal angle, a narrow aortoseptal angle, which will have an impact on disease progression, while in boxers is more of an annulus hypoplasia. And in boxers, you don't think the aortoseptal angle plays
not so much. I published a paper several years ago, but really running on after I realized that that was not really important in boxer. It's really important in golden retriever. About different phenotype, if you watch about the communication at ACBM, in ACBM in '94, probably you were a student at that time or not yet, but you know,
yeah.
I presented.
Let's not make that comparison. Yeah.
Yeah, sorry guys. I'm born in the '56. I'm born in the '56. That's the problem. And so I presented an abstract. Communication was on a different phenotype of aortic stenosis in different breeds. So what we see, and we still see this. For example, Doge de Bordeaux, they generally have this almost the same aspect of the boxer. Aortic annulus hypoplastic, not so much narrow orthoseptal angle. And the difference is they have more frequently post-stenotic dilatation. In boxer, frequently we see even the aorta remain hypoplastic. And that is a contribution. The hypoplasia of the aortic root and the hypoplasia of the descending aorta is one of the contributions that make us to overestimate the gradient, because this is the phenomenon called pressure recovery, described by Bob Levine many years ago, probably 30, 40 years ago. Bob Levine was a great cardiologist, one of the pioneers of the echocardiography in human, and he described this aspect, that, you know, the flow that goes through the aorta in an aortic stenosis have a sort of energy. It's energy that goes with acceleration. If you have a post-stenotic dilatation, huge, like you see in Newfoundland, like you see in German Shepherd,
right?
That you see this flow spread is energy, just warm up the blood there. But you know, this energy is wasted over there. And so the aortic velocity you measure is a certain value, of course, high value, depending on the restriction of the annulus. But in boxer, for example, if they have aortic hypoplasia, what happens? You have this energy that goes toward the aortic wall. The energy is transmitted back to the flow from the aortic wall. The elastic aortic wall retransmits this energy, and you have this relaminarization of the flow, is called. If you have another instrument and not just the Doppler, when we say, oh, this flow, I see in the color, this flow is turbulent. It's not true. If you have just evaluated that it's over the Nyquist limit, and that's it. It's not laminar or turbulent. Yes. So this flow is laminar, and maybe it's 4 meters per second, but it's laminar.
Fascinating.
In hydraulic concept, it's laminar. So there is a different pattern, and it is create an increased resistance and increased afterload. So you estimate the aortic velocity, you overestimate probably the gradient, but it's not so bad to have this overestimation, because you say, okay, it's an overestimation. If I measure with the catheter, will be different. The disease is not less severe, because this effect on the wall and this energy reflected to the flow increase the afterload.
Right.
So, the pathophysiology point of view, this left ventricle is anyway more stressed.
But then, are you using different cutoffs depending on the breed?
Yeah.
You have so which cutoff would you use for a non-boxer dog?
Oh yeah, generally I don't care so much about the cutoff.
Yeah.
But I would not expect in a Newfoundland and a German Shepherd or in other breed, I would never expect a normal dog with a velocity more than 2 meters per second.
Right. And in boxers, I would say 2.2 is probably fine.
Yes, absolutely. I had
interesting.
Again, in that year, in the previous century, I had a lot of discussion with John Bonagura about that. And they were so strongly supporting the cutoff. Bill Thomas and John Bonagura were supporting this. And when I stated that is a very low specificity, even 20 years ago numbers of the Journal of Veterinary Internal Medicine. I even published a study I did in Boxer, measuring the aortic flow just when I put on the table and 20 minutes after the dog was relaxed. And there was 25% change of difference, because even the behavior, when you put a dog on the table, the behavior is different. If you put a Boxer, they push everywhere. They are not aggressive, but they push everywhere, and they recruit all their muscles, and they increase the stress, increase the catecholamine release. You wait 20 minutes, and the velocity decrease. So, in my opinion, it's more important the measure of the aorta annulus is more important the study of the morphology. This is much more helpful for the breeder. The pattern in other breeds like Newfoundland, like German Shepherd, what else, is a different pattern. Generally, it's more severe condition. They have a huge proliferation of subendocardial tissue.
Right.
Frequently, it involves the anterior mitral leaflet, which is thick and stiff, and they have a huge posthernatic dilatation. The phenotype is different. We don't know about the genetic, but breed make the difference in this.
I've always felt frustrated by the use of pressure gradient alone, and many people use pressure gradient alone, either for breed screening or for prognosis. I think diagnosis, fine. We're all pretty comfortable. You've got a gradient of, I don't know, 3 meters per second. That's not normal. Therefore, we'd call it a stenotic or a hypoplastic aorta. But people will look at a gradient and say, oh, the gradient is very high, therefore the survival time will be shorter. And that's just not true, I don't think.
Absolutely,
because
no.
You see these dogs of 8 or 10 with a gradient of 90 or 100 millimeters of mercury. Obviously, for any listeners who are not so familiar with the cutoffs on Doppler, we would say anything over 80 millimeters of mercury is a severe gradient, 50 to 80 is moderate. But it's just not as simple as that for aortic stenosis. So obviously things like mitral regurgitation will play a role, systolic function will play a role in modulating that gradient and making it look better than it really is. I would like to know, at the time of diagnosis on echo, what features do you look for? First of all, in the non-breed screening dog, in the case that's presented with a history of a heart murmur or maybe an episode of syncope, what features do you look for apart from pressure gradient to try and advise the owners on prognosis? And I think the second part of that is for breed screening. Who do you worry about most in those cases?
I completely agree about this point. This is the experience of everybody does our job. So, the gradient alone doesn't tell everything. Doesn't tell everything when you make the diagnosis, but people want something easy to do, and breeders want to have a cutoff.
Yes.
And the cutoff, they have to the breeder to trust your opinion outside a cutoff. You need to be a strong influencer on this breeder, so they have to trust you, because otherwise they want to deal in the way they want to, the way they prefer. They want to they diagnose.
And they're knowledgeable, aren't they? Many breeders, they know the breed well, So you've got to win that trust. I think you've got to earn that trust.
Yeah, but in the normal case, so outside of the breed screening, when they come, it's so deep. There is for any disease, for any pathophysiology condition, there is some part that we have not understood yet. That's the history of the medicine. So in medicine, you say never say never, never say always. So there is some change. I have seen a boxer dying at 12 years of age with 120 of gradient, and they live all their life with 120 of gradient. Less probably in other breeds, because in other breeds generally more severe. Only Dodge de Bordeaux are quite similar to boxer. Dodge de Bordeaux are quite similar to the boxer. They probably develop much easier the Deutsche de Bordeaux, the systolic dysfunction, the afterload mismatch. But I think they have even a bigger heart, because the problem to develop the afterload mismatch is when you have a bigger heart, so the radius, the diameter of the left ventricle is higher, and the wall stress is much higher. We are writing now a paper on our case on PDA, for example, and the systolic dysfunction after closure. So the uncoupling of the ventricular arterial uncoupling on the left side, these occur in large breed dog because they have a bigger heart. If the heart is smaller, so it's much less important the afterload at that level, because they have a ratio between the wall thickness and the cavity, which is higher. And so it's the same for PDA. If you have a Maltese, or if you have a Chihuahua, they may develop much easier an Eisenmenger syndrome, but they don't develop easily, or I never seen in my experience, but I cannot exclude some sort of this systolic dysfunction. The same of subaortic stenosis. I've seen even small breed dogs, Dachshund, for example, with subaortic stenosis, and they tolerate quite well this.
Claudio, regard the pressure gradients, because that's a really interesting topic. So let's say that, okay, pressure gradients are not a holy grail, are not a magic number. Totally agree. And now, if we start having also systolic dysfunction and so on, do you think there is a place to do VTI ratios to calculate effective orifice area? Or what do you do when you start having systolic dysfunction? What do you do on echo to assess the severity of the stenosis? What's your approach?
My indicator on the follow-up of this patient, my indicator is the relationship between end systolic volume and aortic flow velocity, peak gradient and mean gradient. The peak gradient decrease, the mean gradient decrease less, because it changes the shape of the flow. The ratio between pre-expulsive period and left ventricular ejection time is a good indicator as well. That was used in dogs, in human, for many years before the advent of the echocardiography. And unfortunately, it's in Italian, but I published a paper in 83, 84, probably. I was doing this value with a polygraphic system in a boxer, using the carotid flow, the carotid pulse, and the apex cardiography. So the shape of the apex flow. So that the prehistory, this one. Anyway, the relationship between systolic diameter or systolic diameter, because M mode is enough. M mode is very good. S mode is repetible. S mode have a temporal resolution much better than any other system. That's fine. So the systolic diameter or the end systolic volume, if you prefer, a relationship with the aortic flow, but even the diastolic diameter may increase, because that they start to develop the preload reserve. They start to develop a preload reserve. The reason why they get better, they are asymptomatic for a shorter period compared to the electrical myopathy, but they have some preclinical stage. It is because they prepare a sort of preload reserve, but they have the obstruction. So when they go on afterload mismatch, I realize from decreasing of the aortic flow, the end systolic volume, the problem is you need to have an history of this patient after they are stabilized on the beta blocker therapy. Because
so it's changed over time.
Yes, they change over time, even if they are on beta blockers. The crucial point for this patient is, I treat this patient, because someone develop even pulmonary edema in the acute phase. But the prevalent problem is the systolic dysfunction.
Right.
And if they develop a pulmonary edema, you have to give some diuretic, of course. But if you give diuretic, you reduce the filling of the left ventricle. And then you may increase the peripheral resistance, and you reduce the cardiac output, which is already poor. Someone say, then you have to stop the beta blockers. I don't think it's so important to reduce beta blocker or to interrupt beta blockers. If you interrupt beta blockers suddenly, you have a storm of arrhythmias.
Sure.
And you do not protect anymore the myocardium. And if you take out the beta blockers, they increase the eventual increase of systolic function is due probably to the release of catecholamine and nothing else. I think probably low dose of beta blockers should remain, that's my opinion. But on the other hand, you don't have any other medical treatment to use, because if you use pimobendan in someone who has an obstruction could be not a good deal.
Would you ever use pimobendan in a dog with subaortic stenosis or aortic stenosis that's in heart failure, poor systolic function?
Yeah, someone will use it, but I'm not sure about the result, because when they are in overt after all this match, with this kind of patient have a life expectancy which is much less than a dog with dilated cardiomyopathy. I never seen one of these dogs survive more than 6 months.
No, I would agree with that. Do you think that fits your experience, Jose, as well?
Totally agree. But that was a very good question, Kieran, because I was wondering when there is afterload mismatch, if you would use a positive inotrope, because you could say that the left ventricle is not able to cope anymore with that fixed obstruction. But that's a good point. We don't know. Can I just give a step back, because beta blockers are, I know how fond you are of beta blockers and how much experience you have with beta blockers. So we would love to have your experience on that and opinion on that. So when do you start atenolol on a dog with aortic stenosis? When do you make that call? How do you decide that?
I don't think there is something precise to say, but generally when they have a gradient which is more than 80, I give beta blockers. So, but beta blockers, is a drug which is extremely important in human veterinary medicine. In veterinary medicine, we don't talk so much about beta blockers. Probably we don't talk enough about beta blockers, but there's the simple reason that there is no one drug company who produces beta blocker for animals, and so it's not mentioned. It's like the aortic. Nobody talks, but this is the crucial point of the cardiology therapy. And I would say that beta blockers, there are fans of beta blocker and people who don't love beta blocker at all. I remember when I was working more on pediatric cardiology, my mentor was against beta blocker, saying it is not necessary. And I was giving beta blockers to all child with tetralogy of Fallot, all child with pulmonary stenosis before intervention. I was treating with the beta blockers. And anytime he was waiting the case to say, this is a demonstration the beta blocker is useless. Sometimes, so we discussed it, we are still discussing after 30 years, because sometimes when I go back, and I hope now retiring to go back more in pediatric cardiology, they were still discussing about that. So in my opinion, beta blocker helps anyway, because improve the myocardial perfusion, reduce the stress of the myocardium. But if I have to go back in retrospective to watch my data, I can't, because I give beta blocker to everyone.
On our previous episodes, we discussed a lot about using troponin I and then holters and so on to assess myocardial damage potentially. Is there a place to measure troponin I to assess the degree of myocardial damage, or to do holters to decide when to start beta blocker, or we just rely on the
No,
gradient?
I rely only on the gradient and the hypertrophy. Right. If they have hypertrophy, especially, of course, I consider beta blocker mandatory. That's a nice point. Some golden retriever, some even in other breed, but mostly in golden retriever, you may identify puppies. They are in Dalmatian. In Dalmatian, we have several cases interesting. They have a particular aspect of the subaortic stenosis. You see puppies, mild murmur. The murmur worsen when the puppy is excited, and the gradient it's much more evident when they are excited. You can see, and there's a sort of dynamic stenosis. And I think there is vicious circles when they are puppies. Dynamic stenosis create hypertrophy, the hypertrophy create dynamic stenosis. if you treat with beta blockers when they are puppies, you may cure this. I had several puppies that I treated with high dose of beta blockers, so more than 1 milligram per kilogram, 1 or 2 times a day of atenolol. And in Dalmatian, I have seen those one not treated, they developed a severe aortic stenosis. That one treated, since they were puppies 2 months of age, they do not develop any subaortic stenosis. When I see this, of course, this is a different pattern. It's more dynamic stenosis. When I see this kind of dynamic stenosis, I start with massive treatment beta blockers until they develop completely. I remember Fox Terrier. I tried to take out the treatment, to interrupt the treatment when they were normalized the flow after 1 year of treatment, and immediately the dynamic subaortic stenosis appeared again.
That's really interesting. So I think, to share my very limited experiences, similar breeds, actually not Dalmatian, but I've seen 3 or 4 pointers, German short hair pointers.
Yeah.
So similar genetic background, I presume. They look the same apart from the spots and the coat. I think I've seen a couple of working terrier type dogs as well.
Yes.
Jack Russell Terrier was one.
Yeah. The pointer, I remember 1 pointer in my life with subaortic stenosis.
Some people would argue that this maybe could be mitral valve dysplasia, causing systolic anterior motion of the mitral valve and obstruction. And then as they develop and the mitral apparatus may develop as the dogs grow, the obstruction may become less severe. What are your thoughts there? Do you think could be the mitral valve the main trigger for the obstruction and then the secondary hypertrophy? Or would you still classify this case as a subaortic stenosis?
I think, there was a nice study done by cardiac surgeon Newman, presented in if I remember well, in one of the European Congress of Echocardiography, that was talking in Newman about malposition of the mitral apparatus. I say the mitral apparatus, all the mitral annulus and the valve, it's quite rotated, and that creates a misalignment of the anterior mitral leaflet. That's probably what we see in cats as well. But I would say the mechanism of the anterior mitral leaflet that create the obstruction, could be due to 2 types of reasons. One is the malformation of the outflow and the mitral apparatus, which are quite connected. And just enough some change in the developing, some misalignment during the development that create these fissure circles. On the other hand, this phenomenon, it could be acquired and acute. For example, I have a nice image I put on my book of a dog dehydrated with chronic hypertension. So typically is the chronic small dog with chronic renal failure that arrive dehydrated with a left ventricular hypertrophy because of the systemic hypertension. And when they are dehydrated, they develop severe subaortic stenosis. You just give fluid and this subaortic stenosis disappears. It's the same in human. It's much more evident because I remember a patient, she arrived in pulmonary edema and was in continuous rate infusion of furosemide. We did an echo, and this dehydration was worsening her mitral regurgitation and worsening the obstruction. You have to figure out in intensive care when after the echo, we say, give fluid this patient. Fluid is a pulmonary edema. No, she was a pulmonary edema.
People always get very confused when a cardiologist recommends giving fluid rather than taking it away.
Yes, but that in that case, you may have an improvement. So there is some mechanical interaction. But what is my feeling, my experience in these puppies? They were in the period of developing, and everything was developing together. If you let this kind of obstruction when they are developing, the hypertrophy get worse. But with this stress and this shear stress on the leaflet may create thickening and may create a further obstruction, and further obstruction may create hypertrophy. I had, in golden retriever, what you may see is the fibrotic spur. You may see, I've seen several cases with the fibrotic spur just below the annulus on the septum, and this fibrotic spur worsening in the ear. I remember a golden retriever that was very mild gradient when it was 1 year of age. And so I say to the owner, don't worry, that's a very mild gradient. You will not develop anything bad and worse. So these guys showed me this dog, and they had this little fibrotic spur, from a very mild gradient, he arrived to have 120 until 150 of gradients after 7 years, because that is the shear stress on the fibrotic spur. It's just a sort of tip.
So you would say in those cases that have got obvious morphologic change, that are diagnosed very young, that you'd consider beta blockers as a preventative intervention?
The beta blockers in this case may work well, but doesn't work, in my opinion, when you have the fibrotic spur.
Okay.
If the hypertrophy is fine, it works well. For example, I don't know if you have this breed, but in Italy it's very old fashion, the Czechoslovakian wolf. It's a sort of inbreeding between Carpathian wolf and dogs like German Shepherd, what else? They are beautiful to see.
I look forward to treating my first one.
Yeah, that's of course the attitude is quite a wild animal. But anyway, they have sort of malformation that I'm not sure that this is a genetically inherited hypertrophic cardiomyopathy or is a subaortic stenosis, because they have such a severe hypertrophy and sometimes not severe gradient. Wow. But the hypertrophy looks like a cat. Sometimes they have mild hypertrophy and obstruction with this misalignment. I treated someone with beta blockers with good results, but it's a not so much diffuse breed. We can do some speculation, pathophysiological speculation, but not enough data.
Very interesting. Can I just ask you, Claudio, because there have been now these two recent papers comparing atenolol with sotalol, with slightly different, small studies, but interesting results. So the one from the Oregon state showed that maybe sotalol would decrease systolic function more than atenolol based on volumetric measurements, I believe. And so they postulate maybe sotalol would decrease myocardial oxygen demand and could be better than atenolol. And the second retrospective study from Wisconsin, they showed that sotalol, or their data suggest that sotalol was associated with an increased risk of sudden cardiac death. What are your thoughts? Do you ever use sotalol? Or
not so much, no. I have the rule that when they have arrhythmias, we use more sotalol than atenolol. Generally, the choice of atenolol, I think, is related mostly on the owner compliance, because they have to give only once a day, in some cases 2 times a day, but generally only once a day. Sotalol, you have to give 2-3 times a day. And generally, the breeder, they forgot to give this the treatment regularly. But on theory, sotalol is more active on arrhythmias. I'm quite surprised to listen, they find that more in sudden death, more cases of sudden death with this. I think when we use statistic in these studies, we have to always consider so many factors, different history, the kind of patient you treat, and so to attenuate this bias, you need to have thousands of cases treated together.
Right, and that's the problem, isn't it, with our
it's the problem in veterinary medicine. If you compare the study done in human, at least 1,000 cases, then we talk about, we say it's a lot of cases when more than 100.
Yeah,
that's the limit. Yeah. About the arrhythmias, I think you find more frequently arrhythmia and severe arrhythmia when you see on the echo quite evident subendocardial infiltration of the hyperechoic tissue. Is a disease of the subendocardium that start, in boxer, you see always localized below the aorta in the annulus. If you watch German Shepherd, for example, when they have this, they have so much thickening of the subendocardium everywhere. Sometimes they have diffusion even on the right side. So I remember I was discussing about that with a cardiovascular surgeon in children, and he came to see me before dinner. We were just chatting. I showed him some image and some pathology specimen, and he said, this to me, I would classify as a sort of fibroblastosis. Probably it's not, we don't know, but I think there is a genetic difference, very different phenotype. Probably is less frequent because, when the form is so severe, it's self-limiting in the diffusion. All the German Shepherds I've seen with this form, they die older for systolic dysfunction, or they die suddenly very young, before 1 year of age. So I've seen 2 or 3 of them dying suddenly during a fourth.
It's very interesting to hear your thoughts on that hyperechoic subendocardial appearance on the echo. I'm never sure how to interpret that. It's quite settings dependent, isn't it? And dog dependent, your penetration of the ultrasound, whether you have the harmonics turned on or not. And I think for us, because we do a lot of echo, right? So we're used to our machines, we're used to our settings. But I think for people who are maybe a little bit less experienced than us, or maybe don't have a machine that costs $100,000 or whatever, actually it's more challenging, isn't it, to see that more subtle change?
I think for understand that we need to practice or to watch as much we can the pathology specimen.
Yeah.
For the patient, I'm quite committed with my resident to push them to collect the heart after the dog die. Your patient die, you have to watch the pathology specimen. I have a collection, an enormous collection of pathology specimen, and even my book, all the image I put, almost all the image I put, I have the echo, I have the pathology specimen, and sometimes the histopathology.
That really struck me looking at your book. Actually,
helps you to understand.
Yeah, it would be a good chance just to promote your book, Claudio, because Kieran and I, we just
is what I'm doing.
No, that's good, because Kieran and I, we just looked at your aortic stenosis chapter, and exactly as you said, it's beautiful. The images are outstanding, and as you said, it's so neat to compare the echo images with the gross images and histology. That's it's great images and very, very useful.
I'm looking forward to reading the whole thing. I have to say, I think it's going to be a great.
I think in echo for subaortic stenosis, you have to be ready to see any strange things you will never expect. If you watch now, you have a look at the chapter 5, but you haven't seen the video. I've seen cases, for example, where you see some redundant tissue from the anterior mitral leaflet get caught inside the left ventricular flow tract.
Yeah, I saw a Cocker Spaniel with this.
Yes.
A couple of years back. I looked at it and thought, I wonder, could we just snip it out surgically? Is there something we could do there, because it's tissue that was completely redundant and obstructing, contributing to the obstruction.
That's probably is the easier surgery for subaortic stenosis. You can repair the mitral leaflet or cut out the redundant tissue. Sometimes it happens. You have redundant tissue or false chordate tendinous less. Generally, is probably redundant tissue developed during the developing of the mitral leaflets, during the developing of the endocardial cushion, and they may create obstruction as well.
That's a great timing to ask you about surgical and interventional options. So what are your thoughts about first intervention? Is there a place for cutting balloon and high pressure balloon. What's your experience? What are your recommendations?
You know, a cutting balloon and high pressure balloon have been tried many years ago. In dogs, I think the reduction of gradient is temporary. It's never definitive. I don't think it's there is. I don't propose that to my client. Generally, I don't propose that to my client.
You know, some years ago, I've done a few of them. I mean, 15, 20 cutting balloon, high pressure balloons. They've all been very clinical. Syncope, mild heart failure signs. They've all improved, but it has been temporary. It's been 12 months, 24 months.
Yes.
They've all re-stenosed, as all those surgical cases in the old literature did.
You know, Kieran, the problem is the same with surgery.
Yeah.
I would say that I cannot say surgery is better, because even with surgery, if you do the septotomy,
right,
the problem is if you go to do the septotomy, if you go too much in deep with septotomy, that you have the risk of the need of a pacemaker at the end of the procedure. And doing the septotomy, it depends on the experience of the cardiovascular surgeon, but you know, the risk of relapse and the risk to have the same gradient after 6 months, 1 year. I remember some children having the same gradient after a few months, and that was very sad. But you know, that's the point. You know, even for example, the alcoholization of the interventricular septum.
I was going to ask you about that.
Yeah, you know, alcoholization of the interventricular septum is something that you indicated in human in hypertrophic cardiomyopathy. If you have obstructive hypertrophic cardiomyopathy, it makes sense. It's treated. You can go through the interventricular artery. You go on the first diagonal, interventricular, paraconal, have several names. But anyway, it's the first road that goes down from the left coronary artery. From that, you go on the first diagonal and you inject the alcohol, and the alcoholization creates the retraction of part of the muscle. There are some interventions that do a good job with this, and if it's a muscular hypertrophy that create obstruction, it may help. I don't know if it's realistic to propose that in dogs because of the difficulty, because of different size. In a human, getting the coronary is easy. In dog is not difficult, but go in the root.
Into the correct branch, right?
Yeah, it's quite small. And probably we don't have the right cases. We don't have the right cases to do that. You know, it's remain... I think the key point of aortic stenosis is all focused on prevention. Then therapy, or I don't know. You know, you mentioned balloon. I've done several balloon, somewhat successful, somewhat not, on aortic stenosis, aortic valvular stenosis.
Right.
That's a good point, because you know, I think it's like in human. If it's a bicuspidia, the success is temporary. It's not. If it's dysplastic with fusion of leaflets, you may have more success. Of course, you know, you are ballooning against the stream, against the bloodstream. Compared to pulmonic stenosis, you are against the bloodstream. So the important is to use two things in my experience. Reduce the heart rate when you are ballooning. We use
fentanyl or something to drop the heart.
Fentanyl is fine because, you know, in children we use adenosine. Adenosine is fantastic for that, but in dogs it doesn't work.
It doesn't touch dogs.
No, the dog do not react. You know, adenosine in children, especially in a child with supraventricular tachycardia, so it's quite common in a 6-7 years old child. They arrive at the emergency with supraventricular tachycardia, pale, scared, and with the parents, of course, scared. And you give adenosine, it's fantastic. And you give adenosine during intervention in children. The dogs, the heart stop for 5-6 seconds, and you can do whatever you want.
Yeah.
But in dogs doesn't work. What I use in dogs, I use the temporary pacing. And even if you give 250 beats per minute, to have a reduction of the pressure is so difficult.
Yes.
I don't know why, but they remain with high pressure. Of course, the goal is to reduce the blood pressure. Generally, I was using, to use a pacemaker related on the right side. Now I find much easier. I use, I don't know if it's sort of malpractice, but I do that. I use the same guide wire of the balloon. The guide wire is touching the tip of the apex of the ventricle, and I stimulate through this.
Wow.
So I don't use the femoral vein. I just use this one. I stimulate 250 beats per minute, and then we inflate. The important is the ratio of the balloon with the annulus, 1 to 1.
1 to 1. So very different from Aortic Stenosis cases, aren't they?
Yeah, because if you have just a moderate reduction of the gradient, I prefer to have a moderate reduction of the gradient than to have an acute aortic insufficiency due to avulsion of a leaflet. That is going to die, sure. That is going to be a disaster. But in my experience, I had only reduction of mild reduction, or sometimes more than 50% reduction of the gradient. That's fine. If there's a bicuspidia, is like in human. I don't know why. That probably is more elastic.
Can you comment on that? Because that's an interesting subject. So bicuspid aortic valves are like the most common congenital heart disease in humans. We see it sometimes in dogs. What's your experience? How frequently do you see bicuspid valves that cause no problem, no insufficiency, no stenosis, versus, and how many cases do you see that will be associated with insufficiency or stenosis?
That's going in my private. I would say I have a son with aortic bicuspidia. That was a bad discovery. Because one of the engineer of ultrasound company called me and say, I have to meet you in the children's hospital to try this machine, and say, unfortunately, I'm at home with one of my son. He has fever. I'm alone. My wife is working. I have to say, okay, don't worry. It's a portable machine. I come to you. We use the machine with your son. Okay, fine.
He was very keen to make the sale, hey?
This bastard came to me with the machine. I know when I saw my son with a bicuspidia, he was 4 years old at that time. And so I was so stressed and scared about this point. And, now is probably you have seen when you came in Milano, is a boxer, and is an athlete, is very exercised. Why?
Yeah, sure.
Because, at the once I had the occasion, it was a course, an European course of echocardiography in our children's hospital. And one of the organizers say, okay, you have 3 boys, bring your boys as a model. Say, okay, fine. So the other one, I use it he has a beautiful window, and I use it for show the 3D. This one, the second, the middle age, one of the professors was there, was a major expert of aortic bicuspidia, and I told him, check my son, and she says she's a woman. She said, Claudio, years ago, we were just not aware about that because he had an aortic bicuspidia without raphe. So it's just 2 leaflets equal, and they just open like this and not asymmetric. And because if they have the raphe, so means the thick line of the fusion of one is bigger and the other is small. And you see very well on the short axis, mostly in systole, because the diagnosis of bicuspidia should be done in systole, not in diastole. Diastole is misleading.
Yeah.
You watch in systole, and then it's open like this. The only thing I check with my son, I do echo every year to measure the dimension of the aorta, because in human they develop also aortic dilatation, aortic root dilatation. Until now, he hasn't. And in dogs, I've seen the same huge aortic dilatation. For some,
really, with the bicuspid.
Yes.
Right. Okay.
And that's an interesting point, because you see, there is two theories. One of they are doing a study on genetic on this patient, and one is supporting the idea that it's a sort of genetic disease of the aorta.
Like an aortopathy rather than a valve disease.
Yes, absolutely.
Particularly. Yes, yeah.
Yeah, the others say that probably is most a physical problem. If you have this small leaflet and bigger leaflet, the flow goes eccentric.
Right.
Going to impact the aorta in one side and then make a turn, and you see sometimes the diastolic flow going back. And so this is the reason why they have sometimes such a massive aortic regurgitation. It's not only because of the leaflet, the difficulty of closing of the leaflet because of malformation. So if they have, and I've seen the same in dogs, if they have no raphe and so symmetric leaflet is fine, they have a good evolution. In human, they may develop mineralization, calcification, but in dogs, I never seen that. Probably they don't live enough, or they have different metabolism. But if they have asymmetric leaflet, they have dilatation of the aorta, and they have this kind of regurgitation, and they have generally severe stenosis.
Right.
Since I'm doing the promotion of my book, you will see the image. You will see the image of a cocker that has this kind of asymmetric leaflet. I did a balloon, it worked well. After a couple of years, he came on the emergency after a diarrhea with the neurological symptoms. The emergency had the neurological symptoms, with this disaster of neurological symptoms. And he had developed an acute endocarditis with thrombus that went on the brain.
Right.
And we developed also a fistula between the valsalva sinus and the right ventricular flow tract. And we showed the pathology specimen, the localization. That's unfortunately what we should expect on aortic bicuspidia, this kind of aortic bicuspidia, because of the turbulence. And after the ballooning, probably is much more evident. I had another case, a boxer with aortic stenosis due to dysplasia. We did a balloon, was in 91. I was doing the balloon, was me. Peter Darby was visiting me.
Oh, Peter, yeah, he's a friend of mine.
It was with Peter. He was my mentor. And Eric de Madron, that now is in USA. We did this balloon. It went very well. But this dog was a boxer. He had also some epulit on the mouth, so he needed surgery on the mouth. They say don't do any surgery for at least a couple of months. Don't do that. They went to the vet. They did it. He developed the acute endocarditis, very severe.
Oh, no.
But I think they need this care. In human, if they have aortic bicuspidia without any regurgitation or stenosis, we don't give any medical treatment, for example, before going to the dentist. If they have insufficiency or stenosis, it's recommended amoxicillin the day before going to the dentist.
Okay, and that's an important thing that I think we do recommend to our cases that have got even subaortic stenosis because of the jet lesions against the aortic valve. I think we accept that's likely to be a risk factor. I was going to ask, regarding endocarditis and aortic stenosis, do you have a cutoff of severity? Now, I know we don't love absolute cutoff, but is there a severity of aortic stenosis below which you would say that's too mild to worry about endocarditis? Or would you treat every case the same?
About the question interesting is about how much are predisposed the subaortic stenosis is endocarditis compared to the aortic stenosis. I would say, at least my feeling, valvular stenosis, probably much more predisposed to endocarditis. And the subaortic dogs, I've seen just few ones compared to the enormous quantity of subaortic stenosis I've seen. I remember just a couple, 3, 4 cases, probably no more. And I think what is more evident, if you follow the patient with subaortic stenosis, if you have the luck to have this pathology specimen of an advanced age dog with subaortic stenosis, you see a severe thickening of the aortic leaflet, but just a thickening, because the jet impact lesion creates thickening. And that is the question when you do echocardiography. You say, oh, you may have aortic stenosis and subaortic stenosis together. It's not true, probably. And then you see, yeah, but you see the leaflet do not open completely. Yes, but of course, the flow is concentric because of the subaortic stenosis.
Right.
So they move like this. But you know, you don't see a doming. You see just they open that. That's very difficult, I think. And you need to be an echocardiographist quite experienced to stay there.
And I think because they're quite distinct pathophysiologies in terms of the origin of the disease, those subaortic lesions are very different to the valvular dysplasias. So the dog's very unlucky to have both, isn't it? And I think we see that a lot, just the asymmetry of flow leading to asymmetric opening, which can have the appearance of fusion.
Yeah, that's it.
Claudio, can you give us your opinion about valve replacement? Is there any place for catheter-based transvalvular replacements?
Okay, I think depending, if you have the right dog with the right size of the annulus, because of course the valve are produced for human, and you need to have quite a large annulus. So that means if you have a boxer, for example, there is no one valve that can fit on a boxer. But if you have a dog with more than 20 millimeters of annulus, I would say transversal diameter, that is never the right perfect diameter, that probably doing something that Brian Scanson did, we can do that. Brian did on, if I remember well, on after an endocarditis. And
that's right.
Yeah, that's you have a normal annulus. If you have thick valve, it's not a problem. You can do that. I don't think it may worsen subaortic. It doesn't make sense.
Sure.
But if you have an aortic valve stenosis and a thick valve, you can balloon first, strongly balloon first, because you don't have to take care about the insufficiency. Then you can put one of these prosthesis. You know, the problem is, one of the concern is to choose the right valve. Because, you know, in human, it works well because there is the calcium around. We did it with my father. My father at 89 had this surgery.
Wow.
He lived very well until 92. And he was a cardiac failure for aortic stenosis. But you know, he had a strong, big piece of calcium around the annulus. And that helps you to fix the valve.
Okay.
You can put there and you can fix the valve. Without this calcium, probably they can be unstable. And you know, the last point is the cost of this valve, which is enormous. Right. Enormous. You know, the alternative could be a biological valve, surgical implanted. Surgical implanted, of course, require cardiopulmonary bypass.
Yeah.
And, you know, and with the cardiac arrest, and so with cardiac arrest and cardiopulmonary bypass, need a team enough experienced. But I would say that biological prosthesis, surgical implanted, sutured, if you don't need to do the prosthesis even of the aortic root, like in the Bental procedure, if you don't need that, the cost of the valve is very cheap.
Right.
That is affordable. I think for a normal client is affordable. Just a few €1,000.
Right. And I think, you know, when I spoke to Dr. Scanson at Colorado about his experience on this case, the valve costs $35,000. for the transcatheter valve, which I think for the vast majority of canine patients, there's no way someone can fund that.
They will not be. Right. And you know, the problem with this device that costs so much for us is also that it's so expensive that you are not going to do so many cases. So we will not go through the learning curve.
We'll never become good, right?
No, you never. Because, you know, to be good on a procedure, you have to do, you know, I always say that there is no one difficult procedure and an easy procedure. What you do once a year is difficult. What you do every week, it's easy.
Yeah.
You know, in the department where I was working in pediatric cardiology, the room aside, they were doing a human intervention. So this team, they were doing more than, they were implanting this kind of valve, more than 300 cases a year.
Wow.
They, of course, they become expert.
Yeah.
Everything you get an expert if you do every day.
Yeah.
If you do once a year, it's difficult. That's the problem of many procedures we did together, no? That's amazing.
Yeah, sure. I mean, you know, Claudio and I have worked on the TEER procedure together, and it's a real learning curve. I mean, it's a real learning curve because it's completely new to both of us. The device, the handling, the approach.
TEER, it's much more difficult than implant an aortic valve. Implanting an aortic valve is not so difficult with the right instrument, the right, you know, the advantage they have in human. They have software dedicated on the CT scan, and they elaborate the CT scan, and they have the perfect measurement of the aortic annulus or what else. We have it because now we have a cardio CT with 128 layers. So we can do that. We are trying, but we are still much far away to get to have some conclusion.
Yeah, that's a whole other learning curve, isn't it? How to image using advanced 3D modalities.
Even make a measurement. You can make a measurement, you know. We recently put some covalent stent in case of systemic to pulmonary collateral. Right. And you know, making measurement with this software dedicated for human in dogs, we had some difficulty. We had a case that we put the stent and then we immediately realized that we had to put another bigger stent. Wow. Because the measure was wrong. You know, it's a learning curve to adapt. You know, I'm probably the most experienced in the translational medicine because of the both profession. But you know, translate everything is not so easy. There is so many differences and so many different situations that takes time, and to have a common experience shared. For this, I'm so happy to have this podcast. I prepare myself for the next.
It's really great to have you.
Because talking with you is a stimulus, fantastic to think about, and to interact with people like you is so good because you ask the right question. I know where you want to arrive when you ask question, and so that came out information that probably will be so good for people. You had a great idea.
You know, for us, doing this podcast is all about the conversation. We don't really care if people listen. We're very happy to have people listen. But this is what it's about for us. And
now it would be interesting, for example, to talk about the right ventricular flow tract malformation. I say that on this way, not talking only about pulmonic stenosis. There are so many patterns of pulmonic stenosis.
Oh yeah,
and we are facing so much problem now with the French bulldog.
Oh yeah, and I saw a case yesterday that I thought on physical exam I thought maybe had subaortic stenosis. It's a 12-week-old golden retriever, grade 5 murmur, not quite like an aortic murmur. And I thought, oh, I wonder if this is aortic stenosis or not. And it's got a double chamber right ventricle, you know, an infundibular stenosis, a fibromuscular stenosis. You know, they're tough cases. And there's a whole other podcast there, I think, on these right ventricular outflow tract malformations. I think that'd be fascinating to speak to you again. Maybe we should do one that's a panel discussion. So maybe we could invite you, Claudio, and maybe Dr. Scanson and somebody else to come and share thoughts on that.
Yeah. What we generally do, Claudio, if that's all right with you, we're going to ask you now to give us 3 key messages that you think are important for people to remember after this podcast.
Yeah, for cardiologists, I would say that on breath screening, don't consider only the gradient. Don't be fixed on the gradient. Don't be fixed on the aortic velocity. Just to try to explain that to the breathers, that important the anatomy, because the anatomy doesn't change during the exam. Aortic velocity may change.
Yeah.
Another point, it's about the identification of afterload mismatch. Please consider all data. I would say in echocardiography, I'm used to say that it's a sort of common way to say, at least in Italy, I don't know where, we say that if something is like the pig, you don't know anything, you use everything. Echocardiography is like the pig, you use everything. So
I like that. I'm going to remember that.
Consider any data, but be focused on the pathophysiology behind it. I have to identify if this patient reduce his cardiac output because of the disease. Why reduce his cardiac output? Because the afterload is winning against the strengthness of the left ventricle. So follow the right ventricular dimension. Don't be focused on the fractional shortening. Sure. Fractional shortening is something for people who want a number. I never watched the fractional shortening in echocardiography. You watch the diameter, you watch the shape of the ventricle. If the ventricle become round, the asystolic volume or the diameter, what else, increase. And the peak gradient decrease and the shape of the flow become round, that patient is starting to have afterload mismatch. This the good news is you can do that by echocardiography easily and very early. The bad news, there is not much drug to treat that. And about the medical treatment, is controversial, the question of beta blockers, but I am probably not the right person to give an independent opinion because I would put beta blockers in the public water.
You Cuban cardiologist, all about the beta blockers.
We have just to suggest to the hypothyroid people, drink only sparkling water from the bottles. For the rest, use beta blockers. Anyway, be focused on the anatomy to identify aortic valvular stenosis, aortic bicuspidea. We haven't mentioned quadricospedia, but quadricospedia generally give a bleedal insufficiency, not so important. I've seen only one case having a severe insufficiency, but it was just the other one. So recognize this, recognize the anatomy, focus on the anatomy and the change of the function and the form and function. This is my refrain.
That's fantastic. Great. That's fantastic. Claudio, thank you very much. It was great to have you here. It was a pleasure and we learned a lot.
Yeah,
thank you.
Me too. I learned a lot. Thank you. Thank you, guys.
Thanks, Claudio.
Great. Thank you very much for listening. Please follow us on socials. Our handle is @heartbeat_pod. We will soon have some new episodes, so stay tuned.
Thanks, everybody.